Okay, Mr. Chairman, thank you for the nice introduction, and thanks for the invitation to this talk. I have no conflict of interest with Tendyne by itself, so there is an unmet need definitely on severe MR. And on this slide we can see that first 49% of patients in severe MR cannot be operated because of high risk, and on the other half, for reasons I will not detail, those patients who are surgical candidates are not, in fact, referred to surgery. So mitral regurgitation is the most prevalent valvular heart disease, and surgical repair has shown a durable and effective standard care for patients with primary MR, which is not the case for secondary MR with no impact on survival with surgery. So what about transcatheter repair, which has been very well studied last session yesterday? In the CRAP trial, as you can see, there is still a residual MR, which is an important issue. And the issue is so important that the MR is related to the mortality. So we know that also there is a learning curve which is still significant, and there are also a lot of limits, including the MAC. So in this very interesting study which is being published, they compared MitraClip with Tendyne, and as you can see, after a MitraClip there is 92% of moderate MR, where there is 100% minimal or zero MR. The LV volume does not change after MitraClip, whereas the LV volume is decreased after Tendyne. The RV function does not move, whereas it increases with this Tendyne valve. So what is Tendyne? It's a system which is first has a double stent device, one to land the valve on the mitral annulus, and the second to support the free leaflets. And then you have this tether design which separates the sealing from securement, and enable full retrievability of the system. And then you have this tendon which will make a continuity between the valve itself and the apex. And I like that because it mimics first the native mitral valve, and also, as it was very well explained by Dr. Kamioka before, it helps to avoid a parallax or an angle, dangerous angle between the valve and the axis. So there are in fact two profiles: a low profile with a surface of 2.2 square centimeters, and a standard profile with a 3 centimeters area. In fact, the yellow is the standard, the blue is the small, and you can see the two stents, which is in fact one for stabilizing the valve and the second to support the leaflets by itself. So, in fact, the equipment here is a loading system as usual, and then the delivery tool as the valves, and then the specific device, the pad positioning system. So this is a cartoon to show very briefly. In fact, it doesn't show that first they dilate to avoid the system to be blocked, and then the valve is positioned under TE control. If the control is not accurate, not satisfactory, then it can be retrieved, as it's shown here, or it can be just released. And then the very important point I did not mention is the entry point. The entry point is very important and will be defined before with CT in order to be sure that you don't make a mistake with this axis, which will give the quality of the positioning of the valve. So the data. First, 100 patients from Soraya. It's a very tough real-world population. The key exclusion data were LVF less than 30% and LVDD greater than 70 millimeters, severe mitral calcification, and prior surgical intervention treatment for mitral aortic disease, and severe tricuspid regurgitation and severe arterial pulmonary hypertension greater than 70 millimeter mercury. Here you see the patient characteristics. The NH class is 2/3 3 to 4, prior MI 57%, prior CABG 47%, heart failure hospitalization within 6 months 39%, so prior stroke or 16%. It's a very heavy risk population. Primary MAMA 11% and secondary MR, which is a real issue, 89%, STS from 7.8%. So the complication in 3 groups, I just summarize everything there. Basically, it is cardiac arrest, arrhythmia, and heart failure on the beginning, and then it will be again cardiac arrest, arrhythmia, and heart failure. There are few other considerations we have not time to study, but I advise you to look at the paper in JACC from Müller this year. The 2 years follow-up, including 1 month, 1 year, and 2 years, regarding the mitral regurgitation is excellent, with no mitral regurg after 1 month, and after 2 years there is a mild regurgitation of less than 7%. And this translates into an excellent NIHA functional classification. Almost two-thirds at the beginning, baseline 3 to 4, and at 2 years it is the contrary, more than 80%, 1 and 2 NIHA class. So this is translating into, as I told you, a decrease in LVED volume, as you can check in this nice publication of Fukui. And then very quickly, the 5-year outcome in these 2 patients, very pilot study, with a persistent result in the fall in the New York Heart Class Association functional class, an increase in the walking test distance still persistent at 5 years, and I have no time for going to that. Let's go to the Tendyne in severe MAC, which is also the limits, very important limits of the current repair. So, primary study of 9 patients with 100% implant success, LVOT obstruction with 1 case, no complication, and then the 30 days outcome, which is really outstanding: 0 mortality, 0 stroke, 0 myocardial infarction, 0 heart failure, and so on. And the valve did not migrate, was not malpositioned. So, importantly, about furnish for the beginners that we are tools and that we will begin to be, a procedure planning with reconstruction of the valve and the MAC, and also a virtual creation of the Tendyne inside this MAC situation. And as you see on the top what they plan, and on the bottom what they did. And it is amazing to see how it was able to foresee the situation, even in a very complex situation. So based on this full implantation of Tendyne in severe MAC under compassionate use, they intend to do a special study with MAC, which was at the beginning, if you remember, a contraindication. So the Tendyne clinical program, global feasibility study, we saw the first 100 patients, and then the Summit IDE trial that we will see quickly, and then the MAC trial, 30 patients up to 10 clinical sites. So the Summit new study design in 3 parts: a randomized study looking at the survival free of heart failure hospitalization at 12 months, a non-randomized part which looked at all-cause mortality, cardiovascular hospitalization, all stroke or mitral valve reintervention or reoperation at 12 months, and then the MAC specific study, survival free of heart failure hospitalization at 12 months. I gave you 1 month. So let's go to the patient profile and selection. So the CE mark, in fact, is close to what was the inclusion patient, moderate severe to severe mitral regurgitation greater than 3, with a left ejection fraction greater than 30%, with a left ventricular diastolic less than 7 millimeter, life expectancy less than 5 years, without prior mitral intervention and without severe mitral annular calcification. So the contraindications are quite easy. Who cannot tolerate procedural anticoagulation or post-procedural platelet anticoagulation regimen, sepsis including endocarditis, evidence of left ventricular arterial thrombus, vegetation or mass on the mitral valve, and very important, with a thin or fragile apex rendering the subject unsuitable for transapical procedure. So the Tendyne screening is the fusion of TE, TTT, and CT. So this, as I told you, is the construction of the device plus the valve itself, and it will give those dimensions, the perimeter of the valve, which will allow to show, in fact, the size of the valve with a slight oversize. I have no time to go over that. These 40 CT images, very important to really understand how to avoid the LVOT, for example, obstruction, and to precise exactly how the entry point of the apex will be chosen in order to be perfectly orthogonal. So the CT requirements are very important. ECG-gated contrast kind of the heart, a slight thickness less than 1 millimeter with slice interval less than 1 millimeter, full cranial caudal heart coverage, and full image matrix. So let's go to this 75-year-old woman, congestive heart failure hospitalization, but minimal morbidity. As you can see, the MR is really severe, and both LV and left atrium are much dilated. So the new LVOT assessment will provide 3 things: how to envisage the prosthesis inside the mitral annulus, and the distance between the A2 and the septum, very important to foresee the LVOT obstruction. And as you can see, the axis with the point, the entrance of the valve, showing the right apex entrance. So the valve deployment on the left, the valve is deployed here, and the control by echo Doppler with a perfect result. So the procedural and 1 month post-op CT assessment, as you can see, the valve is well adjusted with the MAC. It is really impressive. So the long-term consideration speak about anticoagulation therapy, which is mandatory for any bioprosthesis in mitral high risk of thrombosis, and also the necessary of antibiotic therapy. So in conclusion, this valve is a highly performing mitral valve in a high-risk population. We showed on the preliminary result an excellent procedural success and mid-long-term follow-up, and broadening the limitation of the mitral clip to extreme limit, severe MR, secondary MR, MAC, and reconciliating with transapical access. Thank you very much.